Okay, good afternoon. I am going to talk today about the class 3 malocclusions, about the use of the aligners in kids during the mixed dentition, and we talk a very interesting topic that is the alternative, invisible alternative to Invisalign and to aligners. And we are talking about the use of the removal plates or the active removal plates in adults. And also we are talking about the low cost treatment in adult patients. Okay, to start, remember my multi-technique. Today we are going to treat about the class 3 treatment in young and adult patient, invisible low cost treatment in adults, the use of the DSQ multi-technique in adult patient combine different appliances, fixed appliances, removal appliances, the use of the active removal appliance with aligners, the use of the aligners in kids and adult patients, and the orthodontic treatment in dysfunctional patient. This topic about the treatment of a TMG patient, I'm going to talk in this presentation in different clinical cases. Okay. Remember, in our multi-technique is something new in orthodontic. In my opinion, there is a division between the classical orthodontic and the aligners, the Invisalign, and the clinics, the different clinics around the world now divide, like in schizophrenia, the clinic in classical orthodontic or aligners. In my idea, this is a different. The first step is the diagnosis, the plan of treatment, and third, you have to decide the biomechanics of the patient, and four, in the last part of the protocols of diagnosis and the plan of treatment is to select the appropriate appliance. Okay, we use brackets and wires. The use of the idea is to diminishing the number of arch wires because every day I talk about this with my colleagues. Please forget the old-fashioned techniques. What is an old-fashioned technique? It's a technique we use a lot of wires to get the working wire. For example, to starting with 16 or 14, 16, 18, 60 by 22, 70 by 25, 90 by 20. Okay, forget this. It's possible today to treat a lot of patients only using a couple of wires and only using one or two alloys. Most of the clinical cases in my office today, we are using the thermal wire, thermal supraelastic wires, and combine at the beginning of the treatment and use the gunmetal for leveling, for closing space, and the gunmetal, in my opinion, is the ideal arch wire for finishing because it's very easy to bend the wire into the mouth. It's very easy to adapt the wire to the slot of the bracket. What is the main problem? The main problem is the new wires, the gunmetal, then in night-tie copper wire, supraelastic wires, TMA, beta-3 titanium, titanium molybdenum alloy, titanium niobium alloy. All the new wires need a new design of bracket. And a new design of the bracket is not only to put a cap. Okay, most of the passive and even active, most passive self-ligating brackets present only this, a cap. And what is the real differences between a conventional bracket and a cap and a bracket with a cap, the cap. The synergy bracket present is not a very new bracket because it's a classical bracket like is a different brackets, okay? It's a different bracket, like a deep edge bracket. This is an old-fashioned bracket, but it's a, in my opinion, a very nice bracket. The same in the synergy, present appropriate slot, adequate slot for the new alloys and the new wires. Present three pairs of winds. The central wind is over elevated, okay? They elevated, and when you put, remember, the ligature in the middle or in the different slots, you can control the orthodontic tooth movement tooth by tooth. Okay, the next is the digital. Okay, today the digital possibilities to diminishing the time of the treatment, and you can diminishing the time of the treatment is possible thanks to the new alloys, the new selection of wires, the new sequence of wires, the new design of the plan of biomechanics to simplify the biomechanics, and something very important, another very important point is the indirect bonding. It's possible to put each bracket in each tooth, okay, on each tooth, with a very extremely precision. What? Thanks to the indirect bonding. Microimplants, we development with the Siacom company, the DSQ orthodontic system, comprehend the use of the intraoral comprehend intraalveolar microimplant and extraalveolar microimplants. In our idea of our microimplant, this is in a titanium number 5. I think it's very important. The alloy, in this case, the titanium number 5. I don't recommend to use the low-cost stainless steel. Because it's a problem. If you have a problem with your patient, okay, you have a very big problem if the microimplant is not a very legal microimplant, okay? It's not a very with all guarantees of the quality. And I in many cases, the stainless steel low-cost Chinese microimplants represent a serious problems for your patient. I think it's very important the extra-alveolar microimplants because improve the biomechanics, simplify the treatment, especially in the adult patient. Okay. Another topic very important in our office is the digital functional appliance. What is the idea? Very simple. To align the teeth with brackets and wires. Why? Because the brackets and wires is the most effectiveness system to align the teeth. Invisalign or aligners is a good appliance, but is a little bit slow, the alignment of these teeth. It's very comfortable for the patient, it's very comfortable for the professional, but I think it's very important to divide this. The idea of the functional appliance is to put the functional appliance in the same phase of treatment that the fixed appliances. The patient is using at the same time and combine both systems. The fixed system, 24 hours a day, and the removal appliance only using at home and during the night. Okay, for the reason we are talking about in the first point about the class 3 treatment, and I remember when I starting orthodontic many years ago in the 80s, the 100% of the patients with class 3 was treated, almost in Spain, almost in Galicia, in my region, was treated with a chin cap. Okay, chin cap was the most important or the most relevant treatment of a class 3 years and years ago. Today is the opposite. Most of the class 3 malocclusion, okay, use at most in the first phase of the treatment the rapid maxillary expansion in combination with the facial mask. Why? The first problem is why? The first problem is this: the uncertain effect of the chin cap in on the TMG, okay, and maybe I don't know, but maybe it's possible to produce problems with at the level of the TMG when you apply a lot of force in the condyle. Why? Because the compression of the hard bone of the condyle in the soft tissues of the retrocondylar soft tissues, and this is very rich in with the nerve, with the fibroblast, with the vascular activity in this area. For the reason I use the chin cap only with dental, no orthopedic effect. I am looking the dental effect. Why? Because the chin cap is, in many cases, is excellent appliance to get a good deep bite. After jumping the bite, after the resolution of the anterior cross bite, okay, maybe with a removable plate or with another appliance, is I like very much to use the chin cap to avoid and to eliminate the habit, to avoid the protrusion of the mandible, okay, after the correction of the crossbite. Okay, we are using with this objective. But the main objective of and the most popular treatment today is the use of the rapid maxillary expansion at the level of the maxillary with a facial mask. Why? Because there is a very some curiously because 60% of the effect, okay, of the successful effect of the combination of the rapid maxillary expansion and the facial mask, 60% is a maxillary effect, but 40% is a mandibular effect, according with the different researches, different papers from different authors, and I would like to remember the Peter Nagan researches. Okay, it's important to treat the patient with a rapid maxillary expansion and the facial mask independent of the diagnosis of the class 3, independent of if the patient presents a maxillary problem or a mandibular problem or a mixed problem. Yes. Why? Because when you use rapid maxillary expansion and facial mask, remember this. Without treatment, the estimate growth of the A point is about 0.5 millimeters a year if the patient presents a genotype or epigenetic tendency to the class 3. 1 millimeter a year, the forward movement of the E point, when the patient is class 1. And please remember this: 3 millimeters a year, the forward movement of the A point, okay, when you put the rapid maxillary expansion and facial mask. And this is very important when we are talking about the evidence-based orthodontic or evidence-based treatment. Why? Imagine a father that don't want to waste the money, okay, to spend money in the orthodontic treatment of his very young daughter, and ask me, Dr. Suarez, do I have guarantees about the successful of the treatment, because the treatment is very expensive for me and I need guarantees. I never I never give guarantees to the parents. When I explain this, if you put the appliance in your class 3 doctor, maybe it's possible to get close to 5 millimeters, even 6 millimeters, if the patient use the rapid maxillary expansion in the facial mask during a couple of years. But only 1 millimeter a year, only 1 millimeter a year, if you decide, okay, to avoid treatment or you decide to forget the mandibular class 3 of your data. And I think it's very important. It's very important because 6 millimeters, 5 millimeters in the face in 2 years is too much. Okay, for the reason, the most important characteristics of the class 3 is the anterior crossbite, but it's very frequently the association between the anterior crossbite and the posterior crossbite. When you have the complete crossbite, anterior crossbite and posterior crossbite, please, you are thinking in a skeletal and maybe surgical class 3. Okay, it's possible to have a maxillary component or a mandibular component. Okay, in many patients, the structure of the skeletal relationship of the patient is a class 1, but do an anterior crossbite, do the propioception of the anterior incisor or the contact of the anterior at the level of the anterior incisor, the patient move the mandible forward. The name is a false class 3, neuromuscular class 3, functional propioception class 3. But remember, some patients present both skeletal class 3 and muscular or functional class 3. Okay, in another cases, the patient present a apparent class 1 with a very more or less nice or correct interincisal relationship, a good interincisal, but you can see what is the real situation. The real situation is a true class 3. For this reason, the first step, the same in class 2 and the same in class 3. The first step, please, even before the analyze the cephalometric analysis or the 3D, the 3D cephalometric with the CBCT, the first step, please, analyze the dentoalveolar compensation of the class 3. Because the orthodontist is excellent work when the patient presents a descompensation of the class 3. And the work of the orthodontist is very hard when the patient presents in class 2 or in class 3 a compensate malocclusion. Thinking, for example, in a patient with a very proclined incisor in the lower, in a patient with a class 2, or the opposite, a protrusion of the upper incisor and retrusion or retroinclination of the lower incisor in class 3 patients. For this reason, we have in many cases a functional propioception in class 3, and the most important characteristics normally is a protrusion of the lower incisor, the protrusion of the lower incisor, the protrusion of the lower incisor, the retrusion of the upper incisor, and in many cases present a posterior crossbite. Okay, in the opposite, in the functional proprioception of the class 3. What is the result if you move the mandible, take the mandible and put the mandible in central relationship or close to central relationship? You can see the dramatic change of the interincisal relationship or interincisal molar relationship. For this reason, we have when the patient presents a maxillary class 3, rapid maxillary expansion and facial mask. For the reason, this is a joke, it's a joke, but I don't like the class 3. Why? I don't like to treat class 3. I don't like to talk about the class 3. Why? Because the class 3 treatment in most of the techniques, MBT, Roth, in Damon, is the same treatment. Class 3 is the same, with rapid maxillary expansion, with facial mask or with mini plaques or with mini implants, and finishing with class 3 elastics. Okay, this is the typical treatment of class 3 in my office. In a patient present the typical anterior crossbite, posterior crossbite, anterior crossbite, posterior bilateral crossbite. You can see in the nose the short vertical dimension of the maxillary, okay, because the maxillary present a 3-dimension hypoplasia, and the treatment rapid maxillary expansion. Okay, what is the agreement? And I don't like to talk about class 3 because it's the same. It's possible to listen to another speaker from Damon, another speaker from Roth, another speaker from MBT, another speaker, whatever. Okay, and all the speakers talk about the same with the same cases. For this reason, I like very, very, very much to talk about the mandibular class 2. Why? Because my vision about the mandibular class 2 is completely different to a lot of techniques. Okay, class 3. Maybe the most effective is in the primary and early mixed dentition. Only depends in my office of the level of the grade of the eruption of the first upper molars. Remember that the best is the combination between the facial mask in conjunction with a rapid maxillary expansion, more than 5 maximum force, 5 or 6 100 grams per side, and almost 12 hours day and night, maybe 8 hours during the night and 6 hours a day in the afternoon. Okay, what is, according with Peter Nagan 1997, the effect? Is a 40, more or less 40% mandibular effect and 60% maxillary effect, more or less 50% for the skeletal effect, 50% for the dental effect. This is the typical patient with class 3. You can see the hypoplasia of the maxillary, the hypoplasia, the characteristics nasolabial sulcus, the protrusion of the mandible, the a little bit collapse of the posterior part of the upper airways. The crossbite posterior, anterior, okay, and the typical treatment. This is the rapid maxillary expansion. This is a McNamara fashion, the McNamara fashion. The McNamara fashion in the rapid maxillary expansion is about 0.75 millimeters a day, about more or less 15 days. Okay, this is the more or less the standard in my office. 0.75 a day, 15 days. This is the screw. Okay, this is the screw, and this is a conventional screw. And you can see very nice how is the effect. The first effect is the increase the forward movement of the A point. Next, the growth, stimulate the growth of the maxillary, something very important. Stimulate the proprioception way, of the upper incisor, the eruption of the upper incisor increase the overjet, and the retro position of the mandible. Now the mandible, the condyle, is more close to the fossa, in the fossa, is more close to the centric relationship. The retro inclination of the lower incisor, I think, is very important. Because the rapid maxillary expansion doesn't produce direct effect in the lower incisor, but the upper incisor, the movement of the upper incisor and the deep bite, and this deep bite produce the retro inclination of the lower incisor. I think it's very important to understand that it's not the direct effect of the rapid maxillary expansion, it's the indirect effect. It's the same with the chin cap, okay? It's the same with the chin cap, okay? Okay, remember this, 0.5 millimeters in class 3, 1 millimeters in class 1, and more, 3 or more millimeters when we are using during 1 year the orthodontic treatment. And I think it's very important. Okay, the dramatic change of the maxillary and the position of the mandible, but in this patient, you can see the temporary success of the treatment. Why temporary success? Because you can see the long face of the patient, the length of the lower part of the third of the face, and especially in my opinion, okay, and I think it's what is the difference between the dentist and the orthodontist? The most important is the dentist works with the teeth, and the orthodontist, the field of the orthodontist is the face. Teeth for the dentist, face for the orthodontist. The orthodontist changed the face thanks to working in the teeth. The dentist work in the teeth, and the work of the dentist is the teeth and the immediately surrounding soft tissues, the periodontal tissues. For this reason, I don't like the dentist, and I like very much the orthodontist. Okay, and you can see here in this patient what is the worst of this patient. This length, the length between the the lips and the chin, because in the more or less the correct proportion is 1/3, and this is theoretically 2/3. Okay, in this case, the main problem of this patient is the height of this part of the profile. What is the problem? The main problem is this: the growth of the mandible and the pattern of this patient with the mandible. Okay, okay, and okay. For this reason, this is the protocol in my office. After the first phase of the treatment, normally in my office is 1 year and a half, but 1 year is okay. In my office is first phase, 1 year, 1 year and a half. Fees, about 1,600 or 800 euros, okay? And something very important, please finish the treatment in the first phase. Second phase is another treatment, completely different to the first phase. And please, it's a very good advice for you. Please, please, don't use appliances during the first phase of the treatment and the second phase of the treatment. Why? Because if the patient presents in the second phase of the treatment, imagine an example, a canine included in the palate, okay? For the parents, the problem depends of you. But when the patient is free of treatment and present a canine in the palate, in the father, parents thinking about the problem is the problem of the patient or the problem of the nature. Okay, okay. For the reason, 10 years, finish the treatment. 13, 14 years old, 3, 4 years later, we evaluate, we see the patient in my office one or two times a year, and 3, 4 years later, evaluate the face and evaluate the occlusion. When the face and occlusion is okay, I am very happy and I need to put brackets and wire or even with aligners to finish the treatment. When the face is not very nice and the occlusion is okay, you have it to the decision of the treatment depends of the patient, normally depends of the parents. When the face is horrible or bad, and the result of the first phase of the treatment is the result is not very good occlusion, but maybe the result of the treatment, thanks to this treatment before treatment, is possible to avoid a very aggressive or more complicated or more sophisticated orthodontic surgery. In this third case, the treatment is orthodontic surgery. Normally, the treatment is more simple thanks to the first phase of the treatment. In this case, depends of the patient. The first phase, conventional treatment, camouflage, orthodontic system, and in the middle, okay, in the middle, I really, I confess that the depends on the facial aesthetic and quality of life. Okay, because the patient present different types of life, different position in the society, different a lot of things. Depends of this, I take a decision about camouflage or surgery. Okay, I don't recommend a lot the camouflage. Remember the multi-loop technique or multi because it's possible with a multi-loop technique, with a conventional, without loops, okay, even with gum metal and with elastics, it's possible to camouflage, or with extraction or with mini implants, it's possible to camouflage a lot of malocclusions of class 3, but this is not the case, because more important, the most important is the face. Okay, the most important is the face. I have a daughter, Monica, and for me, the most important of Monica is the face. If Monica presented, it's not the case, a class 3 with a flavor to class 3, with a prominent chin, it's not matter if the occlusion is very nice or not. The most important is the face. And for the face, I recommend without DAP orthodontic surgery. Okay, for the reason when I see a patient very young like this, okay, I recommend during the adolescent, okay, do a little bit psychological support, a little bit psychological temporary support. Why? Because the patient presents a very high lung, is a very dolichocephalo patient, present a very huge hypoplasia of the maxillary, present an hypoplasia of this part, present a very long, okay, chin to the lower, from the lower lip to the chin, okay, and I think a huge collapse of the maxillary, a huge open bite. What is the treatment for this patient? Okay, maybe it's possible to treat this patient with rapid maxillary expansion and facial mask. In this case, please, I forget, okay, the patient, be happy, the patient, no problem. Try to have a psychological support to the patient, thinking in the final result with orthodontic surgery. Okay, this is the patient years after and at the beginning of the treatment. Okay, okay, and now it's time to analyze. It's possible to get very sophisticated programs. I am a very close friend of the owner of, no, the ex-owner of Miguel Angel. Is a very smart guy. The Nemotech, the Nemotech company with the Nemotech program. But really, I like very much to use something very simple that is PowerPoint. This is only with PowerPoint. I love PowerPoint. And PowerPoint now present the transparencies. And this is fantastic to analyze. This is the presentation to the patient and the parents about the treatment of this patient. Okay, I put this in these teeth, okay, to explain to the parents, okay, the current situation of the patient. Okay, we analyze, I like very much to analyze the face with the Bjork-Jarabak cephalometric analysis. I think it's very interesting. It's the polygonum to analyze the result. Please, please, please. In the class 3 malocclusion with a vertical discrepancy, always you have to compare the NMB, the cephalometric NMB cephalometric analysis, please, with the Jacobson, okay, width appraisal. The Jacobson is in yellow. Remember, is the vertical, is a vertical to the occlusal plane, to the occlusal functional plane. Okay, this is, and now you can see the huge class 3 of this patient. This is the real class 3 of this patient, and is completely different, the analysis of the NMB according with the width appraisal instead to the Steiner cephalometric analysis. Okay, the difference between the anterior facial height and the posterior facial height, the gonial, the gonial angle, the different length, the height of the face, the medium part of the face and the low part of the face, okay? And now I explain to the patient and the parents that the first step is to move forward the maxillary. The next step is to the intrusion of the maxillary. And the third step is the to try to cut the mandible and to put the chin, to move backward the chin. Okay, the first step is to move the maxillary according with the true vertical line. This is the aesthetic line of the face according with the forehead and with the nasum. Okay, I like very much to move a lot, the maxillary. When you move a lot the maxillary, the first step is in fashion, because today people love the protrusion of the teeth, the protrusion of the lips, the protrusion of the lower part of the face. Then the second problem, in Galicia, in Italy, in Portugal, Spain, in France, I don't know, in Russia, the people have a lot, big nose. For this reason, it's very important to move forward the maxillary, excuse me. The forward movement of the maxillary in some patients avoid the surgical of the mandible. Okay, and it's possible to treat a lot of class 3 patients with the surgery only at the level of the maxillary. Next step is to the intrusion, the lephor, okay, the lephor number 1 or lephor number 1 extend to produce the posterior intrusion of the maxillary. I need the intrusion of the maxillary for the anterior rotation of the mandible. And I need the anterior rotation of the mandible for two main objectives. The first is the correction of the posterior rotation of the mandible, and the more prominent, to produce a more prominent chin in the patient, and to rebalance, okay, the proportions of the face. According within in green, the occlusal functional plane, now it's time to produce the intrusion of the maxillary. And now, according with this new functional occlusal plane, now we need to move to produce according with the axis, the rotation around the axis of the condyle, or the final high axis of the condyle, produce the anterior rotation of the mandible. For this reason, it's very important to get a very good compression, or understand very well the cephalometric analysis of prediction of the surgery, because you can see with the anterior rotation of the mandible improve the vertical dimension or the vertical balance of the patient, but now the anterior cross-biased situation is worse, because increase the sagittal discrepancy, increase the sagittal class 3. In this moment, is time to the Obegeiser Dalpon, or another technique, surgical technique, to produce the mandibular setback, okay, the mandibular setback, and now we have a patient with a class 1. Okay, you can see the surgery, the change of the profile with this I don't have time today to explain how the PowerPoint is fantastic for this, and this is thanks to the mathematical curve. Okay, when you are drawing the PowerPoint or in a conventional mm, program with images or draws, you are working with a special logarithmic curve, and with the logarithmic curve is possible to is the language of God, or the drawing of God, because the logarithmic curve is the common curve in the nature. Okay, now it's time to the first phase of the treatment is discompensate the malocclusion. I don't like to talk about surgical orthodontic. Why? Because orthodontic treatment is very simple. It's very simple. Only discompensate the malocclusion, only discompensate the malocclusion, and only align the upper and the lower. In fact, the bad orthodontist like to talk about the combination of orthodontic and surgical treatment between prosthesis and aesthetic and orthodontic treatment. Why? Because the main the main work of this not very good orthodontist is only to align the upper and the lower. In fact, if you have a very brave, a very good orthodontist and a bad surgeon, your case is a complete disaster. If you have a bad orthodontist, but a very good surgeon, maybe your case will be very successful. It's not the ideal, but it's my opinion. And I have a lot of experience about it. For this reason, I don't like to talk about the orthodontic and orthodontic surgery, because the 80%, okay, and the 80% of the most important value is the surgical. Okay, we use the class 2 elastic to discompensate the malocclusion, to increase the open bite, to increase the surgical class 3. Okay, now analyze the patient. Is very important. In this photo I like very much, because in this photo you can see the hypoplasia of the maxillary, the need to move the maxillary, okay, to move the maxillary forward, okay, to create a very huge, okay, surgical lever of the class 1 lever or extended lever in the maxillary to move forward the mandible. Okay, this is the patient immediately after the surgery, the final treatment of the patient, and the successful result of the patient. Okay, another very important part of the class 3 malocclusion, in my opinion, is the sleep apnea. Today, according with Guillemon, 2012, many years ago, and Guillemon was the master about the sleep apnea syndrome in kids and even in adults. Guillemon died, I think, 1 year ago. And today, in the field of orthodontia, according with the Guillemon, play a very important role in the diagnosis and plan of treatment, and to prevent the sleep disorder breathing syndrome. Okay, in fact, I done very interesting in treatment in adult patients to use their The dam is the device to move forward the mandible, but I very interesting in the to prevent the sleep apnea syndrome, to prevent a lot of problems in the adult patient working in the craniofacial structure of the kids, thanks to the treatment of these kids. When you combine the sedentarism, when you combine the fat patients, okay, with a horrible diet, without exercise, okay, without move, with the confinement, okay, in the pandemic, and we combine with a maxillary collapse, with a vertical growth, or with a mandibular class 2 in patients with class 2, the result is something very horrible, and is the breathing syndromes or sleep disorder breathing syndromes in kids. And this is a very huge problem because the diminishing the pressure of oxygen during the night, and this is affect to the growing and the development of the cerebrum and the mind. Okay, why is important? For example, in this patient, you can see in this patient with a temporary occlusion mixed in occlusion in class 3, anterior and posterior crossbite, open the suture with classical maxillary expansion, and you can see the result of the patient years and years after the treatment. The adenoids, it's very important, the tonsils, very important, yes, but remember, in many patients, the main problem is not the tonsils, is not the adenoids. The main problem is the dento-alveolar skeletal structure. And this is a problem because I am medical doctor. And remember, I studied 6 years of medicine. And remember, during 6 years of medicine, during the 6 years of medicine, the medical doctor never been or never knows nothing about class 1, class 2, class 3, growth of the maxillary, growth of the mandible, number of the teeth, structure of the teeth, anatomy of the teeth, anatomy, relationship between the tongue and the upper airways, about the relationship between incisor, lips, and tongue. Remember this, when a patient go to the medical doctor or the specialist in pediatric specialist, only check the oral breathing and the relationship between the oral breathing and the adenoids or tonsils. But forget, because it's not possible for the doctor to see a maxillary collapse, mandibular retrusion or mandibular protrusion, anterior crossbite, posterior crossbite, retrusion of the teeth, etc., etc. Okay, we work with the Nemotech company with another colleague about the research about the sleep apnea. We're using the CBCT and the 3D reconstruction of the upper airways, and there is an evident relationship between the anomaly in the craniofacial anatomy, in the craniofacial structure, and the volume, the 3D volume of the upper airway. We work with Professor Cobo from the University of Oviedo many years ago, and published in 1992 in the Journal of Clinical Orthodontic a work about the rapid maxillary expansion with Professor Abel Garcia, the chairman of the surgical or maxillofacial department of my university, working the effect of the upper airway in very severe surgery, like in this patient with a very severe class 3, with a very spectacular mandibular effects, a severe maxillary hypoplasia, and you can see the change of the upper airway when we are treated the patient with orthodontic surgery. For this reason, I am the next vice president of the Spanish Society of the Sleep Dental Medicine. We have a congress in November in La Coruña with the president is Marta Mata, Dr. Marta Mata, and she's an outstanding doctor who studied the problem of the relationship between the sleep apnea in orthodontic. Remember the sleep apnea effects, the brain fog, anxiety, stroke, obesity, impotence, depression, high blood pressure, arrhythmia, low blood, diabetes, and a lot of problems. When we are talking about the countries like the United States, for the United States, it's very important. The sleep apnea is the hidden health crisis. Why? Because produce a lot of social problem. A lot of car crash from train for bus, a lot of loss of productivity, workplace accidents, motor vehicles accidents, a lot of problems. The first diagnosis is very simple in my office, and I work only in orthodontic. I am specialized in orthodontic and work only doing orthodontic treatment, but this is the first step, because in my feeling, the most important of a lot of patients is the long, soft palate. Okay, and the tongue, lengua is in Spanish, excuse me, the tongue drop, okay, and collapse the upper airway. Okay, and I think it's very important. It's very interesting, the cephalometric analysis and even the analysis of the soft tissues in this in this patient. Okay. Okay, I recommend this. It's not, I don't have a research about this, okay? I don't have a research about this, but very interesting. If something is to use, instead to use the 3D combined CBCT or it's very simple. It's to take a couple of cephalometric analysis and with a piece of wax, a piece of wax here, and reproduce the forward and open movement of the appliance. And please, you can check here how to change the dramatic change of the relationship between the tongue and the soft palate. Okay, we use different appliances to treat this patient. Okay, but remember this: the rapid maxillary expansion play a very important role. We published many years ago in 2005 with Dr. Blanco and Zamarron in Sleep Breath, the evaluation of oral appliance in the treatment of obstructive sleep apnea syndrome. And you can see here, okay, we are working with Orthoplus, a Spanish company from Malaga, from the south of Spain, and we use them. Why is important maxillary expansion? For the obstructive sleep apnea. And for this reason, I show you, it's very important, the balance between the craniofacial growth, the balance between the maxillary, the mandible, the alveolar bone, and the concept, the counterpart and the part. Okay, if the first floor present a measurement, I don't know, 1 100 meters square, the counterpart is the first floor and present the same dimension. The same in the face. The anterior cranial base from the nation to cella is the part. What is the counterpart? Is the length of the body of the mandible. Is the length from the gonium to the menton. Okay, I think it's very important to understand this. The same with the maxillary and with the mandible. Okay, when you produce the expansion of the maxillary, at the same time produce the expansion of the fossas. Okay, we publish different articles, and I think it's very important this paper. This is the orthodontist white paper from the American Association of Orthodontists. It's an article of the American Journal of Orthodontic and the Facial Orthopedic in 2019, and it's very important to screen patients to have a very good relationship with the otorhinolaryngologist. Okay, it's important to be familiar with the signs and the symptoms of the obstructive sleep apnea. In my opinion, very simple. The class 3 patient with hypoplasia of the maxillary present a health problem. And the health problem is in relationship with the oral breathing, because the maxillary collapse changed the position of the tongue, and the tongue produced all breathing in one side, and the other side changed the growth of the mandible and produce a more vertical growth. Okay, the change of the vertical growth, please forget the condyle, forget the ramus, forget the body, okay? Forget this, please. It's not a change in the shape of the mandible. It's only a change in the position of the mandible thanks to the vertical growth of the alveolar bone. Okay, in this case we have a skeletal problem. Okay, we have a skeletal problem. Okay, check the patient in centric relationship, and you can see that the contact between vestibular cuspid of the upper, vestibular cuspid of the lower. Okay, present a traumatic occlusion. Check the patient in centric relationship, and even it's possible to analyze in a CBCT, and the main treatment is the best treatment is the rapid maxillary expansion. I prefer to rapid maxillary expansion. Okay, after the rapid maxillary expansion, it's possible to a little bit relapse. Why? This is because it's possible to select two types of treatment. The first step is to produce an over expansion with a rapid maxillary expansion. After remove the rapid maxillary expansion device, I maybe 1, 2, 3 weeks there is a very relapse, but the relapse is not a skeletal relapse. It's a dental relapse, because the patient present at the beginning of the treatment a dental compensation, and you put the removal appliance with this compensation. Okay, okay, this is the idea. The second is more difficult to explain to the patient. Is the first step is to close instead to produce expansion, to close to increase the cross bite, to eliminate the camouflage of the malocclusion, and produce a dental collapse of the malocclusion. And the second step is to produce a rapid maxillary expansion. Okay, this is an interesting idea. Okay, in this patient, rapid maxillary expansion produce like this, and the most important is this. The most important is not the occlusion. The most important and very nice is the face. Change the lip sails of the patient, change the face of the patient, change the nose of the patient, change the eyes of the patient, and in general, you can see the difference. The same in this patient, okay? In this patient, you can see the oral breathing, the permanent 24 hours oral breathing of the patient. The collapse of the maxillary, the lack of space for the canine is not a problem for me, this, but the most interesting is this, rapid maxillary expansion. Rapid maxillary expansion, 0.75 millimeters a day, 3/4 of turn the screw every day, more or less during 15 days. Okay, the before and after, and you can see that the treatment is very fast, using only 6 or 8 months before and after, and the face change completely. Okay, I remember to Martin Bruce. Martin Bruce was the son of Bruce, the founder of Rocky Mountain Orthodontic Company, the first dental company, orthodontic company in United States from Denver, and always Martin Bruce talking about the importance, take care of the children's jaws. For the reason, Rocky Mountain is a company who is with the theories and the hypothesis of the rickets. Remember that one of the objectives of the Quahelis mixed dentition treatment of the bioprogressive technique is to improve the breathing of the patient. For the reason, the breathing is very, very important for the brain, development, for the brain growth, for the health of the kids. A patient with a class 3 malocclusion, the problem of this patient is a retro position or backward position of the A point of the maxillary, collapse between the soft tissues of the palate and the tongue, and the main objective is rapid maxillary expansion and facial mask. For the reason is like a B, C. Class 3. What is the diagnosis? The diagnosis of the class 3 is maxillary, mandible, high angle, low angle, and dolichocephalopatient, brachycephalopatient, mixed dentition, whatever. Treatment, rapid maxillary expansion and facial mask. What is the exception? Maybe it's possible to combine the rapid maxillary expansion and the facial mask in the class 3. Maybe at the beginning of the eruption of the upper incisor, it's possible to use first a Frenkel or class 3 Frenkel functional regulator. This is the maybe. In a class 1 with class 3 flavor is completely different. But in a class 3, the conventional treatment is this. Okay, it's possible even to remove the temporary canines to produce an ankylosis and to use them like a micro implant or bone anchorage system. Okay, And after in many patients like this, I like to show this, in many patients, when you remove the rapid maxillary expansion, we have a problem. And the main problem of the patient is this. The patient presents the habit of move the mandible to the right because the rapid maxillary expansion increase the proprioception of the mandible, and the patient continues with a crossbite. But the crossbite nowadays is a functional crossbite. To treat this and to avoid in the future a more severe problem, okay, because with an asymmetrical growth of the mandible, I recommend to use this. And what is this? This is very simple. This is a piece of composite. We use a piece of composite to check the mandible in centric relationship with the midline. Now it's time to the second phase of the treatment, very simple. I like simplify the treatment. Oh, it's possible to use a sophisticated TMA wire with a night-tie wire instead to use a Quahelis. Forget. Oh, I need to rotate the molar, and it's possible to use a very sophisticated distalization of 3,000 euros. Forget. Oh, it's possible to use a night-tie super elastic Quahelis or something. Please forget. Use something simple. Why? Because the patient don't pay for this. The patient pay for aligners, for something invisible, for clear braces, but don't pay for nothing. Okay, open the mouth, put brackets and wires, okay? A couple of wires is enough with a thermal oil to finish the case, okay? What is my problem in this patient? It's like a problem with the upper first molar. It was very difficult to get down, you can see here, to get down this molar. What is my aptitude? Very simple. I put the retention, cut the plastic of the retention, put a couple of buttons or brackets, a crisscross elastic, and finish the treatment. Okay? Okay, the nice of the patient and the very, very nice of the patient. And what is the most important? The nice expansion, but the most important is this, the upper airway. Okay, for the reason, this is very, very important. Repeat, I am medical doctor. I hate dentists. Hate dentists. To fill in the teeth, to the crack, hate this. But I fall in love with orthodontics because orthodontic, and I hate, and it's a problem with the people now reduce the orthodontic to the alinea dent or Invisalign dentist. What is an Invisalign dentist? It's a dentist who is Invisalign, to use Invisalign only for aesthetic objectives. Okay. You can see here the forward movement of the A point, the forward movement of the A point, okay, and this. Genetic or epigenetic, okay. I recommend to analyze to treat the patient to the reverse way of the malocclusion. It's very important to analyze the etiology, the genetic, the epigenetic, the function, the muscle and the ligaments, the basal bone and the dental-alveolar bone, and the relationship between function, dental-alveolar bone, and the proprioception. Remember that the genetic is like in Greece, in the Greece culture. In the Greece culture, they like very much the predeterminism. What is the predeterminism? remember to Edipo Rey from Sophocles. The predeterminism, according with the Greece, is possible to all your destiny is right in your book, in the life, in your book life, at the beginning of your life. Okay, and it's impossible to change the destiny. Okay, this is the idea of the genetic. This is the idea of the idea. For this reason, it's very important, okay, to analyze the perinatology, the breastfeeding, to treat very early this patient with a severe malocclusion or with the role of the pachyfer, for example, during the growth of the mandible, something very, very interesting. Okay, excuse me for the Spanish, but the idea is we have a dental protocols, functional problems and skeletal problems. And this is the different levels in our University of Santiago, in our research orthodontic service. Okay, we analyze the dental problem first, the functional problem second, and the skeletal problem third. And it's, in many cases, it's true. The epigenetic of the function is very funny when a patient come to the office with a severe open bite like this, okay, or like this, or patient with a very severe open bite like this, with a very vertical growth. It's very important to understand the role of the surrounding soft tissues, the surrounding soft tissues in the tongue inside and the lips and the cheek outside is thanks to these soft tissues control the growth of the dentoalveolar growth. The open bite, and for example, in this patient, this is an epigenetic concept. Why? Because in this is a very simple treatment. Put a very simple, and this I have the photos of this patient, very funny, 20 years after treatment now. Is very, very, very old. And it's funny, I saw in my office 1 month ago, and very funny because I explained to this guy that thanks to this group put this wire, and thanks to this wire with the grill, okay, put apart the tongue and close the bite. And only using this appliance and a couple of brackets is enough to finish the treatment in the first phase of treatment. Remember this case. This is a very old case. Remember, the plan of treatment for this patient in my office, because I like very much, I am professor from university, chairman, but at the same time I have a private practice, and I think it's very, very, very important to have private practice. Very, very important. Okay, forget the practicing in the university. I practice in the university, but it's completely different. Why? It's very funny. Because 90% of the orthodontists in the world have a private practice. And it is very important because we have two objectives. The objective in my private practice is the successful treatment, okay, good service, but profitable treatment. In the universities, research and good treatment for teaching, okay, and it's completely different. Why? This case, I treated this patient with a severe open bite, muscular dysfunction, muscular imbalance of the muscular imbalance of the neck and the face, okay? And the treatment is a very simple treatment. This is removal plate, 4 brackets and 2 bands and 1 headgear. Okay, and what is the fees of the first phase of the treatment. Imagine that the fees today, this is an old case, is 1,800 euros. It's okay. It's a very, very, very profitable treatment for me because I use only the removal appliance, a couple of appliances. Okay, okay. But now, with the man with the hand in the heart, the patient and the parents, okay, now um, like to pay another 2,000 or 2,500 euros for the rest of the treatment. Okay, normal, the patient, the parents, normal, the father said, no, David is perfect with the first phase of treatment. I love you because the first phase of treatment was a very successful treatment and finished very good the treatment and it's okay. Do you understand? What is this treatment in my office? Only 1,800 euros in my office. If I decide to treat this patient later with the excuse of oh no, I don't believe like Roth or like Profit, I don't believe in the first phase of treatment, I don't believe in the orthopedic functional treatment, I don't believe whatever. The real situation is the patient come to my office with a severe open bite, maybe the four canines in a high position, okay? I treat the patient during 18 months, maybe, I don't know, without extractions, but the complete fees of the treatment is 3,500 euros. For the reason, this is very, very important because I respect the colleague that said, oh, please, David, I don't like to do first phase of treatment because for the profitable of the treatment. Okay, for me it's okay. But please, when the objective is this, don't say me. No, I don't like to do the first phase of the treatment because I don't believe in the functional appliance. I don't believe in the early treatment. Please, okay? And I am agreement because the first phase of the treatment is not very profitable. Okay, the problem in many cases is to know if the first is the chicken or the ligaments, the role of the tongue, of the muscles, of the bone. In many patients like this, what is the problem of this patient? Is a tongue, okay, the tongue. The tongue introduced between the upper and the lower teeth, and it's not possible for the patient to close the complete eruption of the teeth and close the bite, okay? And for this reason, it's very important to divide patients like this or the genetic or the epigenetic, for example, the class 3 etiologic genetic, the dynasty of the Spanish king and included the Tsar family and included the Jorge king from England, present huge class 3 for hyperplasia of the mandible, dolichocephalopatient, and hyperplasia of the maxillary. Okay, the class 3 depends more from the hypoplasia of the maxillary, non-monogenetic etiology, irregularity heritage, penetrance about 60%, association with dominant gene MSX1, class 3 associate to different locus in studies of single nucleotide polymorphisms, the human reception genes stand out. For this reason, it's very important. This is a very good doctoral thesis from Marta Morales Fernandez from the University of Seville, 2017, about the results of the inheritance of the class 3 malocclusion. More of the 70% of the class 3 of our clinic present a maxillary problem. Okay, for this reason, it's an epigenetic problem. Nowadays, forget the influence of the genetic. Genetic is very important, but genetic or epigenetic divide the orthodontic school. For example, a lot of people, very popular in Russia, don't believe in the epigenetic effect of the orthopedic treatment, of the early treatment, of the functional appliance. And in a Greek fashion, try to send to the surgery room all the patient with class 3 malocclusion or with a mandibular class 2. But it's a huge mistake. Why? Because today the most important, according with the different studies in the genes and the different animals, okay, the most important is the epigenetic influence. Remember the methylation of the DNA. The methylation, okay, of the DNA is very, very important. And now change from the genetic to the epigenetic, from the grease to the epigenetic. And it's very important for the orthodontist. It's very important, okay, to put, this is a sentence from Spain, to put the sardine very close to the fire. For the orthodontist, it's very important to defend the epigenetic concept. Why? Because the most important in your office, please forget the smile design, forget to put the smile. The most important is to say to the parents, it's possible only with my hands, my instruments, to change the face of your son, okay, or daughter. I think it's very, very important, okay. For this reason, remember the Melvin Moss functional matrix hypothesis, the growth side, not growth center. It's possible to change the face of the patient and the growth of the patient thanks to this. Is my influence is in the growth places. The periphery, the occlusal proprioception, the relationship between the occlusal proprioception and the dynamic of the mandible, the change of the dynamic of the mandible, the change of the muscle, okay, change the dynamic of the mandible. The change of the dynamic of the mandible change the occlusal proprioception. And it's possible to change the occlusal proprioception, but itself with the teeth, or by means the use of functional appliance or appliance who works like functional appliance. For example, if we are using a Quagelis and produce a maxillary expansion, okay, the Quagelis I produce a maxillary expansion, the mandible produces unlock. What is unlock? Unlock, what is unlock? Unlock is to move the mandible forward, okay? Something for this reason, please check the concept. Okay, the orthodontists divide in two groups. Orthodontists with a very good base in craniofacial growth and a lot of orthodontists without idea about the craniofacial growth. And I think it's very important because it's very difficult to understand the result of our treatment without idea about the growth. The tongue is a very important epigenetic element in the class 3 etiology. The upper lip, for the reason in many cases we use the upper lip shields. The tongue in the class 3, the tongue is in a downward position, in the floor of the mouth, and produce an expansion of the mandible and move forward the mandible. Okay, we have to analyze all the elements. Okay, we have to analyze all the elements about the treatment, different elements. I think it's very important. For example, in this patient, the eruption of the upper incisor, you can see the eruption of the upper incisor, the role of the upper lip. Please check this upper incisor very vertical, okay? Very vertical. I am using a lip patch. Why? Because it's very, very useful to eliminate the pressure of the upper lip and to allow to upper incisors to move forward. The famous thumb corridor muscle. Okay, the thumb corridor muscle. Only a patient with a crossbite, very simple. We use a removal appliance, okay, with a couple of shields in the maxillary to eliminate the pressure of the upper lip, and the lower wire here, a wire to move backward the lower incisor. Okay, another patient with the same solution. Immediately after the eruption of the central incisor, when the patient presents a crossbite, I prefer to use a removal appliance with wires. The bite block is with wires, a couple of springs to produce the protrusion of the incisor, and a wire to move, this is a progetic arch, and to use the lower incisor. Okay, with a crossbite, or this patient with a very severe crossbite, put a rapid maxillary expansion with a facial mask, and the nice result years after the treatment. Okay, a patient with a class 3 with hypoplasia of the maxillary. Okay, during the eruption of the upper incisor, I love to use the Frankel class 3. Because it's very ecological appliance, a very ecological appliance. Between use the same forces of the patient, of the eruption of the patient, of the muscle of the patient, of the bite of the patient. In this patient, after the correction of the anterior crossbite, the patient present a little bit an open bite, okay? And in these cases, I use the chin cap only to maintain the mandible close to centric relationship. Okay, the anterior crossbite, the anterior crossbite, the anterior crossbite, and the result of the patient, okay, after the treatment. Okay, please forget the idea of it's very important, the concept of the alveolar bone, The role of the alveolar bone is like a mattress between the maxillary and the mandible, okay? And we use the alveolar bone like a compensation of the bone. This is an example. What is the role of the dental-alveolar process in the equilibrium of the mandible respect to the base of the cranium or respect of the maxillary. The nice word is homeostasis. Homeostasis is a very nice word. What is homeostasis? Is the attempt of the occlusion to maintain the maximum number of contact, independent of the discrepancy, sagittal, transversal, or vertical, of the basal bone of the maxillary and the basal bone of the base. For example, this is a +3 patient. I treated this patient many years ago. I put a a removal plate. I put a removal plate. Okay, okay. And the mother said, David, my son shift the mandible during open the mouth, shift a lot. And it's not a joke, but this was really, it was like a joke, okay. I have an idea many years ago, and was to put a removal appliance in the upper and the lower like this, and put with glue with the upper midline and the lower midline center. Okay, it was a little bit crazy, excuse me, but it was very nice. Starting to the patient use a lot the appliance at home and during the night. It's not possible to open the mouth, but the patient is starting to develop an asymmetrical mandible. And please check the patient with a very severe asymmetrical mandible, the severe asymmetrical mandible, but you can see the nice occlusion of the patient. Why? This is a very interesting. I have a lot of cases like this, but I like this case. I have this case described in my book. This is a case for the reflection. It's very interesting for thinking, okay, critical thinking. What is possible? Why is possible that a patient with a asymmetrical mandible, with asymmetrical maxillary, is possible to get a very good occlusion with orthodontic treatment, with a very simple orthodontic treatment? The secret is this, the homeostasis. For this reason, it's a huge mistake when the people said that, oh, orthodontic is only to align the teeth. Orthodontic is only to align the teeth. When the patient presents a lot of problems, the patient needs orthodontic surgery. And the patient needs orthodontic surgery. This is a huge mistake. And this is in relationship with new concept. Very simple. This patient, class 3, only chin cap. Another very old case, only chin cap, only, no brackets, only chin cap. Put at the end of the treatment 4 brackets in the upper and the lower. What is the objective? The objective is very simple. Ecological proprioception. Ecological proprioception. If you put the mandible in the proper position, the proprioception produces the occlusion of the teeth. The same in these cases, okay? It's possible to treat the patient with class 3 very simple, without brackets, or this patient with a class 3, okay? The patient presents a class 3, a discrepancy in the maxillary and in the mandible. When you put the mandible in the centric relationship, you can see the collapse at the level of the upper and the lower intercanine wide. Okay, okay. What is the problem of this patient? The soft tissues of the upper and the lower lip. For the reason, the treatment very simple. The treatment is very simple. Only a removal plate, a Frankel appliance, and you can see only using a Frankel appliance the spontaneous occlusion of these patients. Okay, the result, part of the result of the patient is thanks to the growth of the maxillary, and now it's time in the second phase of the treatment to close the lower space with brackets and wires. Okay, then I like very much the PowerPoint to the very nice superposition at the level of the eyes. Okay, and you can see here part of the successful of the treatment was thanks to the growth of the nose and the growth of the upper lip. For this reason, it's very important to get the different protocols about the overjet, overbite, the overjet in centric relationship, the dental compensation, the NNB in centric relationship, the widths, okay, and this is a very light case, moderate case, and severe case. For example, when the patient presents an overbite in maximo intercuspidation, an open bite, or a lack of deep bite, overjet is present a crossbite, negative, overbite in centric relationship, okay, and you can see in facial pattern, in my opinion, the worst is a dolichocephalo patient. A skeletal problem, the worst is a mandibular problem, okay? When the patient present a severe class 3 in widths and present a severe class 3 with the Steiner A and B, the dental compensation. When the patient presents a dental compensation, the result of the treatment with orthodontic or even orthopedic treatment is worst. Okay, and I think it's very important to treat the patient as possible, and this is the treatment, okay, with the wires to produce the protrusion of the incisor, okay, with functional appliance, okay, or even a patient with an anterior crossbite, very simple treatment only with Quagelis to produce the expansion of the crossbite. Okay, patient with asymmetrical mandible with a class 3, okay, with a Quagelis, using only a Quagelis, or patient like this with a shift to the mandible to the right, use a Quagelis and a utility arch to finish the treatment, okay? Or even cases like this, I like very much to simplify the treatment. Only put a tube, only put a bracket, and this bracket with a TMA wire is enough with a palatal bar to produce the protrusion of the lateral incisor. Okay, anterior bite planes, okay, okay, and we use a lot this progetic arch to produce to correct the anterior bite. Okay, this is the typical patient with anterior crossbite. With the removal plate, finish the first phase of treatment. Rest period. During this rest period, the patient is free of appliance, and now it's time to the second period of treatment. We are using in the second period of treatment a little bit camouflage of the malocclusion. Even we are finishing with class 2 short elastics and finish the treatment. And you can see the patient, okay, without treatment, without appliances, okay, and this is the typical class 3. Another patient with anterior crossbite, rapid maxillary expansion with facial mask, and the end of the treatment years after the treatment. Okay, another patient, anterior crossbite, okay, removal appliance, okay, because the patient presents a good posterior occlusion. Very important to check every patient with class 3 in centric relationship. Okay, the end of the treatment of this patient. Another patient with anterior crossbite. The main problem of this patient is a very long shift forward to the mandible. And in this patient, we are using like a lingual or palatal arch, metallic palatal arch, combined with a utility arch, a couple of arms to produce the forward traction of the maxillary. And we are using a chin cap. We are using a chin cap to produce the forward movement of the mandible. This is the end of the first phase of the treatment, the end of the first phase of the treatment, okay, and the end of the treatment without second phase of treatment, using only the chin cap, the forward palatal arch, okay, finishing the treatment, okay. This is the main problem. This is the main problem. The patient and the parents refuse now the second phase of the treatment to treat this very little disalignment of the lower incisors. Okay, I think it's you can see the patient years after the treatment without problems. Okay, and finish only using the same. This patient anterior crossbite, put a removal appliance with a very simple removal appliance with we put brackets to straightening the number 11, okay, 11, straightening this, check the centric relationship, and to put the mandible in the correct position, I put this, okay, I put the chin cap to put the mandible in the correct situation, okay. This is the end of the first phase of the treatment. Okay, the end, the same question. Very difficult now for the parents to pay 2,500 euros for the second phase of the treatment, only to correct a little bit rotation and the correct engage of at the level of the premolars. Okay, a lot of patients with class 3, the same, okay, with crowding in the upper years after the treatment and the end of the upper of this patient. Okay, we are in complete agreement about the class 3 treatment, and I like very much to use from the Leone company the special expander, the rapid maxillary expansion screws. Is like a night tie from professor from Italy, okay, and this is very, very nice. This is from Leone, okay. We use the special screw. It's possible even now to buy this special resort or a special loop of TMA, or a special loop of TMA or night tie TMA without a screw. Okay, it's possible only the piece of night tie without the screw. Okay, put in the patient. The first time or the second time or the second appointment, I like to close the system, to close the loop, to close the night tie, and you can see the patient before and after the activation of this special screw or this special system by Leone. Okay, by Leone. Okay, check the patient in centric relationship. Okay, I think it's very important in the patient to check the patient in centric relationship, in patient with a class in patient with crossbite and tendency to the class 3, the same, very important. The contact from the canine produce crossbite and produce a forward movement of the mandible. This is the peripheric comparator, and you can see here the muscle. This the proprioception comparator produce dental-alveolar problem, and the maxillary expansion, need the maxillary expansion, change the comparator, change the condylar growth, the dental-alveolar growth, and you can see here in the patient with a very collapse. Okay, check the patient in centric relationship. Okay, and now open the midline suture. Okay, thanks to the rapid maxillary expansion. Okay, we need to reevaluate. I like to produce rapid maxillary expansion for the influence of the appliance in the fossa piriformis, and I think it's very important to prevent the included canine, the retention of the canine, McNamara or Rosa. I like the Rosa in the early mixed dentition because we don't touch the first upper molars, okay? And we use 3-4 turns to the screw every day, about 0.75 millimeters between 2 and 3 weeks. Okay, open the why we use the composite. We use the composite. Why we use composite? For the control of a good information for the muscles. Okay, and I think it's the most important. This is the most important, and I like very much this case because in this case I talk about the ecological orthodontic. Why? Because we have now a good occlusion. Remember that the patient present an agenesis or a lack of the second lower premolars, and the patient present a nice class 1, a nice deep bite and overjet, and is only using a rapid maxillary expansion and palatal bar. Is enough with this. Now it's difficult to convince to the patient only to use brackets in the upper and the lower, only to align the lower incisor and to get a best occlusion. Okay, I have a lot of cases, but I don't have time to show more cases. I have a lot of class 3 cases. Okay, surgical cases. Okay, the typical surgical cases. Okay, I think it's very important. Okay, it's very important. I have a lot of surgical cases, but I prefer, okay, like the typical patient like this, the patient with a class 3 malocclusion come to the office to try to camouflage the malocclusion. The patient and the parents refused orthodontic surgery, but in my university, at University of Santiago de Compostela, we have an outstanding hospital, with Professor Abel Garcia and 5 excellent surgeons, the same in La Coruña and the same in Vigo. In Galicia, we have a very excellent orthodontist. And the orthodontic surgery in severe cases is included in the National Health Service. For the reason, it's possible for me in my office to treat a lot of patients with and the surgery is free. For the reason I have a lot of patients with a lot of patients with surgery, a lot of cases with in combined treatment. Okay, and I think it's very important because I don't imagine if the patient who come to my office, I explain to the patient that is necessary to the surgery, and the for patient is very traumatic to see or to hear the to see the to thinking in the surgery or and to thinking in the surgery, and I don't imagine if the patient said and you need surgery, and the surgery for you is 15 or 20,000 euros. And I think it's for this reason I understand that the people who recommend the camouflage of the class 3. But the camouflage of the class 3 in the adult patient, remember that maybe produce a very good result at the level of the occlusion, but very bad result at the level of the face. And the most important is the face of the patient. Okay, this is the case. This is a patient who come to the office. Another colleague proposed extraction of the first lower premolars to camouflage the malocclusion. I do this in my office a lot of times, no problem. Or another colleague recommend only the extraction of one lower incisor to adapt to the maxillary in the mandible. But the question of this patient is, I like very much the face of the patient. If I imagine the face of the patient with the mandibular and maxillary treatment. For the reason I recommend to the patient, okay, this is the cephalometric analysis of the patient, the CBCT many years ago of the patient, the very important, the functional occlusion of the patient, the simulation of the patient, the treatment with scenery. Okay, we increase the class 3, and it's very funny because when we increase the class 3 malocclusion, increase the sagittal discrepancy, okay, the patient is like a very ugly and or very old. The fashion is like a old or very okay, and I think it's okay. This is I put the second molars only a couple of months or 3-4 months before the surgery. Or okay, and this is the patient with a lot of class 2 elastics immediately after the surgery. The superposition, the surgery, okay, a mixed impactation of the maxillary and forward movement of the mandible, the occlusal result with a very good result, the occlusal result, and the very nice face. I think it's very important, this. And what is this? Is the change of the face of the patient. I think it's very important, the change of the face of the patient. Don't matter that if you are, it's possible to use a multi-loop technique with TMA, gunmetal, or algiloid, okay, to get a camouflage of the malocclusion. For example, I remember a doctor from Korea, from South Korea. The patient is horrible. The occlusion is nice at the end of the clip, more or less, but the face of the patient is the same. Horrible before the treatment, horrible after the treatment. And the Korean girl, is horrible after the treatment, before the treatment, and horrible after the treatment. And this is not my objective. Okay. Okay. Another question is very nice. Is Now a lot of patients come to my office and demands invisible treatment. Okay, invisible treatment. In my office, in most of the office, not in my office, invisible treatment is the same like aligners or lingual orthodontic. Okay, because I hate the horrible aesthetic brackets that put in a yellow color is horrible. The highness is horrible, and everything in the aesthetic brackets is horrible. Okay, it's horrible that the bonding of the brackets is horrible. Everything. Okay, there is an alternative, and I don't like to talk about the low cost, but really it's a low cost treatment because for a lot of patients, Invisalign or a lot of different aligners is very, very, very expensive. Okay, and with a technician from the lab, with Santiago Ferron, is a technician from the lab, we developed a very simple system to use to treat the patient, or almost to diminishing the time of treatment before aligners or before fixes appliances. The first question is, there is more life beyond aligners. And this patient is possible to distalize the canine and to close the space and to put a simple with a removal 80 no 8,000 80 euros and a couple of composite and elastic if you have a good training. This is the key, because it's impossible. I try to talk with this channel to organize a removal plate seminar, the use of the removal plates in adult patients, because it's very funny. It's very funny because the patient come to the office. I have this canine a little bit forward and this lateral incisor a little bit rotate. I hate to use brackets, and I like to use something like something. Oh, and the alternative is Invisalign, but Invisalign only for this is 2,000 $2,000, okay, or 2,000. For example, this is the classical treatment. This patient could come to my office and said, I would like to Invisalign. Okay, this is a joke. And I said, oh, no problem. And your problem is a little bit crowding in the lower and the lateral incisor in crossbite. Okay, no problem. With Invisalign, the fees is only for you because you are very nice. Only for you is $4,000 or $3,000 or 3,000 euros, excuse me. And the patient said, David, you are crazy. I have only to correct a lateral incisor. No, but okay, it's a joke. What is the treatment? Is this removal appliance, the classical removal appliance. The patient use the removal appliance at home and during the night. Control the expansion with a very cheap 5 euros. The price of this screw is 5 euros. Very cheap. In the lower, please, in the lower is a very, do you like this? We invented this very simple system. It's a removal plate, very simple with LG please, for the technicians. Forget to use, technician, please, forget to use the worst acrylic, the worst screws, the worst materials, the worst stainless steel. Please, you have to change the mentality. Use the new alloys for removal appliance. In this case, we are using LG, but you use a lot the gum metal. And it's very funny. Now, to maintain the occlusion, to avoid destruction of the premolars, and now we put here a clear, very, very, very cheap with glue. I put a clear buttons here. Why? Because I need to put a elastic change here. Okay, excuse me. Elastic change here to control the protrusion and retrusion of the incisor, even to control the torque of this lateral incisor. And you can see the result, and the very nice result in the lower. It's true that you need now to increase the perfection of the patient. It's very funny. Put another appliance, but it's a very cheap treatment for the patient, not for you. The cheap is for the patient. And what is the treatment of this treatment in my office? Maybe the treatment in my office of this patient is, I don't know, 1,500 euros, and the patient is very happy and accept the fees, and I think it's very interesting. Okay, we have, this is the protocol of my removal plates. Okay, my protocol, this is the expansion class 2, division 2 malocclusion. And I come to my office, this patient, and said, David, I like to align the lower incisor. Okay, no problem. It's possible to put brackets in the lower, white brackets or static brackets. Yes, no problem. And okay, in the upper, I need to put brackets to correct the crossbite, or to put a lingual, or to put a quachelis. Oh no, please, David, please not. I like only to use appliance in the lower. Yes, but you have a crossbite in the left, and I need to produce expansion of this canine into produce intrusion of this canine. Oh, but I don't like to use removal appliance. Okay, imagine this patient. What is the cost of this patient? It's possible to put Invisalign. Yes, it's put Invisalign, but the cost is completely different, because the treatment of this patient in the upper is with the removal plate that the patient used during the night and at home. Okay, we can control the expansion, and normally the patient turn the screw a quarter of turn every week, and depends on, I control with the protrusion of the lateral incisor, the expansion, a nice expansion. I don't I don't believe the people who said, oh, removal plates in adult patient doesn't work. Okay, my question is, what was or is your experience in removal plates? And yes, no, I never put one removal plate in another patient. It's very funny. Okay, and I suppose that the people of Invisalign is not very happy with this type of treatment. Okay, because the good orthodontist in general, not only for Invisalign, in general, the good orthodontist, and I am now to write in an article, 3 articles about the crisis in orthodontic in Dental Tribune, in the Latin American edition, and I'm talking about this because it's something very important. The good orthodontist is not a very good customer. Why? Because buy the cheapest brackets for internet, the cheapest material. With the cheapest material, it's possible to do a very nice treatment. What is the ideal customer for the orthodontic companies? The bad orthodontist, who need a very sophisticated lingual 3D appliance with interbonding, with something special to treat simple malocclusions. Which the best is the who is the see a patient say, no, this is a very long, a long Invisalign treatment. We need almost 100 aligners to treat this patient. Okay, this is the best customer for the orthodontic companies. And in many cases like this, with 6 static brackets in the lower, with removal appliance in the upper is enough to treat this patient. The patient is very happy, and maybe the fees of this patient in my office is 2,000 or 2,500. The treatment, the length of the treatment is 1 year or less, in 1 year, 1 year and a half, and it is very, very profitable. Or, for example, in this patient, I use a removal appliance to prepare the patient for aesthetic brackets or for aligners. What is the objective? Is to reduce the time of the treatment time with aligners or the sequence of the aligners. We are using removal plate, okay, put a piece to move the lateral incisor, a couple of screws, a couple of loops in TMA to produce the protrusion of these incisors, okay, a fan screw to expansion at the level of the molar, the canines, okay, and now it's time to treat the patient. It is more easy because in this patient you put brackets, aesthetic brackets in one class 2 elastic and finish the treatment. Another patient with a class 2, division 2, asymmetrical mandible, and she's her mother is pediatrician, is medical doctor, he's colleague from me. The patient present a class 2 and a collapse of the mandible. Why treatment? The main problem of this patient in a sleep apnea, a dual bite and a mandibular lock. Okay, a tendency to dislocation of the mandible for a very, very old trauma in the TMG. Okay, this is our protocol. Okay, the different, and what is the first step? The expansion. The first step is the unlock of the malocclusion to stimulate the proprioception of the alveolar. This is the design. We have a lot of designs of removal plate. Is the question, I suppose that you are, okay, and is possible recommend a removal plate book? Unfortunately, in my idea, there is not a very good book. Why? Because the good books, like a Svarth book or classical book, is a very old book. And the nice new books is not very, very, very good. And this is a big problem. It's a big problem. There is not a very good books about this. Okay, I put the class 2, division 2 removal plate. Okay, the idea is the protrusion of the upper incisor, only with the protrusion of the upper incisor and this small piece of wires. Okay, I bend the wire here and even put a little bit of composite here. Okay, it's enough to align the upper incisor. And you can see with the biplane, produce the spontaneous movement, forward movement of the mandible. But with the same appliance, check this, is very nice. I like very much this because depends of you. Aligners depend of the people who is in charge of your case. And you, what is your role? Oh, my role in the aligners is you have to check a lot. It's not true. You lie. Okay, because the technician decide the attachment situation. Okay, Now it's different. Okay, this is a real different situation. I am using one removal appliance, and it's my colleague. The treatment is free. The treatment is more or less free. The patient is my colleague, is a pediatrician. I try to reduce the fees of the treatment and try to reduce the expenses of the treatment. We are using one removal appliance, and now we need to produce the intrusion of the upper incisor. It's very simple. I put this wire, bend the wire, put composite here, put in elastics, and this is enough to correct the tie. And please check the molar relationship. Now finishing with brackets and wires, okay, and finish the treatment. Please, please, I like very much this type of treatment. I am not a good customer. I am not a good customer of the companies because this removal appliance, the price of the removal of this removal appliance is 80 euros. The price of the brackets and wires of strike wire low friction is about 120 with the 200 euros is the enough to treat a skeletal class 2 malocclusion with a deep bite, with a gingival smile in a patient. Please remember this, okay? Please remember this, okay? Or cases like this. This is a patient from my city, from the TB, okay? And with the removal appliance, very simple, with a little bit of composite. I put here the composite, in a white composite, in the TB, is not, okay, the second is a elastic change here, and it's enough. And now imagine this patient. When I am finishing the treatment, the main problem of the treatment is the forward position of the root. What is my decision? Oh, imagine now to treat this canine with aligners, okay? And you need to put, excuse me, you need to put a couple of attachment, or is possible to put another attachment in this direction, okay, to do this. But what is my problem? My problem is 3 degrees. 3 degrees in each attachment. It's crazy, okay? It's crazy, okay? What is the solution? It's very simple. With a removal plate, I put a hook, okay? I put the hook in white color. I put a composite to put this in white color, okay, to produce the traction. And please, you can check this, not in a lot of aligners. You can see this patient in 1 month. Okay, please, please, please. This is a very simple, and for the patient, this is a patient who, this girl worked in the TB, my local TB in Galicia, and I think it's a very good result, okay? And I use this low-cost appliance even combined with mini screws to intrusion of the molars, okay? This is a patient with TMG problem. What is the first idea? To put in this patient a splint. No sense the splint. The idea is very simple. is to put in a splint, but is an active splint. What is an active splint? It's a splint with a screw. And with this screw, I produce the expansion of the maxilla, the unlock of the malocclusion, the correction of the crossbite, and please check the huge expansion in an adult patient about 50 years old, only with a removal plate, and the price is 30 euros in your office. Okay, and now it's time, okay, to continue the treatment with aligners, or in this case, we continue the treatment. Patient with a very severe deep bite, with a very huge mandibular muscle. Okay, I put a screw here to starting the treatment and the elastic change to produce the intrusion of the incisor. Okay, between this and this, the patient using brackets, okay, brackets in the upper and the lower for finishing the treatment. But the most important part of the treatment was with this type of treatment. Okay, in many cases, it's very simple, a little bit problem, a little bit treatment. Aesthetic brackets in the lower, removal appliance in the upper with LG wires, okay, okay, and okay. And you can see this is our design. Please check the different designs for expansion. I don't have today to explain this, but something is very funny. This is a patient with a class 3, with a close bite, adult patient. I put brackets in the lower, and this type of expansion in the upper. Please check the huge dental expansion of the patient with a very low cost appliance. Okay, it's a very low cost appliance. Please check the before and after the treatment. To align the upper incisor, I put brackets of these vestibular brackets for the lower incisor 0, only using these brackets to align the upper incisor. Why? Because I use only for the first phase of the treatment. The second phase is with aligners or with another type of appliances. The same, this patient come to the office, I would like Invisalign, okay. Is to treat with aligners these two teeth is a little bit complicated. What is our treatment? Very simple. 4 brackets, first 6 brackets, removal plate to expansion, okay, 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 and you can see now to finish the treatment or with aligners or with aesthetic brackets or whatever. Okay, now in the first step you need a lot of aligners, and the second step you need few aligners, and I think it's very important for the length of the treatment. For this reason, in this patient, we prepare with brackets or brackets, lingual bracket and removal, the expansion to prepare the patient for finishing with different appliance. In this case, okay, we need to move forward the mandible. We need to move forward the mandible. We create a space in the aligner, in the removal plate, with a couple of buttons, and with a couple of buttons in the molar. And now, and put 4 brackets, the elastic change here, okay, to avoid the protrusion of the incisor. And now is the situation. Now is very simple to finish the treatment with aligners in the upper and the lower. And now is the time to remove the aligners and to use and remove, the brackets in the lower and the appliance in the upper, and finishing the case. Class 3 with skeletal class 3, the patient refused orthodontic treatment, the patient refused, surgical treatment. Okay, put brackets in the lower, put brackets in the lower, put brackets, class 3 elastics. Okay, you can see here the class 3 elastics. Okay, and now we have a very nice overjet. With this overjet and the stripping in the lower, the class 3 and the elastic and the stripping in the lower is enough to, and the temporary reconstruction of the 4 incisor to get a very good overjet and overbite and finish the treatment with aligners. TMG, ATM is in Spanish, is articulación temporomandibular, is the TMG. Okay, a patient with a problem with the TMG come to the office and said, my problem is I have a pain and I have a clicking and I have a popping in the TMG, and my dentist recommend orthodontic treatment, but I refused orthodontic treatment because, in my opinion, I have a very nice, aesthetic, nice smile. And I said to the patient, it's okay. And I said to the patient, if I put a splint, okay, if I put a splint, use the splint only to relax maybe the TMG, maybe but it's not very comfortable, the TMG, for your deep bite. Confusing me. I try to analyze each patient with TMG in the intraoral problem. First, occlusion, psychological balance of the patient, and maybe problems, neurological problem or problem at the level of the central nervous system. What is my idea about this patient is this. The main problem of this patient, due to the divide in the retroinclination of the upper incisor, the main problem of this patient is this: a compression or retrodiscal compression of the retrodiscal area for the condyle. Okay, this is my diagnosis. I have to check the resonance image of the TMG, but the first step is this. Okay, what is the treatment? Please forget in this patient to use the splint, because the patient paid the splint for nothing. And in the other side, it's very difficult to treat this patient with fixed orthodontic or even with Invisalign, okay, because it's very difficult, the guarantee to alleviate the pain or to eliminate the clicking or to eliminate the sound of the TMG. What is my approach of these cases with a very severe divide? Very simple. The first step is to put composite in lateral incisor, and with this removal appliance, the classical removal appliance by us, DSQ, the class 2 division 2, okay, I put a removal appliance, and the idea is the protrusion of the upper incisor and the retrusion of the lower incisor. For finishing the treatment, I put a white wire with tubes and finish with brackets. I finish with brackets, okay? I finish with brackets in the upper. But the most important is this. You can check the excellent result of the patient, the aesthetic result, the occlusal result, and the patient is very happy without TMG problem. Another similar patient. Class 2, division 2 malocclusion with TMG pain. The neck, the same, retrusion of the central incisor. The first objective in this patient is forget only use the splint and the pills for the emergency the first day or 2 days, but it's absurd to put a removal splint. The objective is to produce the protrusion of the incisor and to correct the expected situation of the anterior teeth. Okay, but the patient refused the orthodontic fees because the problem is fees. The orthodontic fees, because it's very expensive, it's impossible to guarantee to the patient the successful of the treatment. For the patient, the smile of the patient is okay. It's not a problem for the patient. It's a rational patient. We try to transform the rational patient in an emotional patient, okay? And now you can see the effect. The spectacular result only using one removal appliance to move forward the mandible. And now the idea now is to finish the treatment of the patient with maybe with aligners, but the problem is expensive for the patient, for the fees, and at the same time the patient presents an asymmetry of the occlusal plane, or a decalage of the occlusal plane. Fortunately, the treatment of the decalage of the occlusal plane is very easy because we need only a micro screw between the canine and the lateral incisor, okay, and this is very, very simple to treat the patient, and you can see the patient with a very nice aesthetic result, and the most important for the patient is aesthetic result. Okay, I think it's very, very important this combination in my office because I have different levels of the patient in my office. Now, with the crisis of the coronavirus, it's not very easy for the patient to accept a very expensive treatment with aligners, with Invisalign, or with another appliances. And for this reason, it's very important to thinking about this. This is the typical patient. This is the mother of a patient and said, I have a problem with at the level of the TMG, and I check the mouth, check the occlusion, and I see the crossbite, okay? I see this crossbite, and I see the mandibular shift, okay, the mandibular shift. Okay, my first hypothesis about the problem of the TMG of this patient is a pain of the lateral pterygoidal muscle and the masseter muscle in the inner masseter muscle, and maybe luxation of the meniscus. This is the treatment. Check the patient in centric relationship. In centric relationship, you can see cuspid, and the patient asked me, "What is your opinion?" Is two possibilities. The best possibility is conventional orthodontic with brackets and wires. And the other possibility is to, without orthodontic treatment, is maybe to remodeling the canine, to remodeling the canine guide, okay. And the patient refused the conventional orthodontic treatment because hate to put brackets in the vestibular. And I starting with a removal appliance, very simple, a removal appliance with a fan screw, okay, to produce more expansion in the anterior part. The collaboration of the adult patient with this removable appliance is spectacular. Remember this, very important. The price of this removable appliance is nothing because it's very cheap. Okay, you can see here the appliance, and now you can see the evolution of the patient. Now put brackets of the lower incisor bracket. The price of one bracket of this is 3 euros or 2 euros. Is very cheap. Okay, combine the brackets with the removable appliance. Put a crisscross elastic to the correction of the crossbite in the back. And now we are using vestibular incisor brackets, very cheap. Only the secret of lingual orthodontic is, in my opinion, there is a lot of very brave. My ex-wife, Monica Sukia, is very, very, very brave using lingual orthodontic. Okay, she is very good using. She's very good using incognito. Okay, what is the problem nowadays with the coronavirus and with Invisalign? Okay, it's a little bit crazy to use incognito in difficult cases. And in easy cases, it's absurd to use very expensive appliance. The secret is to, in my opinion, this is this is my particular opinion, is the lingual orthodontic is very, very important today with the aligners. It's very important to starting treatment with a very huge irregularity, or very high irregularity index at the level of the incisor, with the overlap incisor, with a huge rotation incisor, with a canine, with upper canine, lower canine, huge rotation and in mesial inclination of these teeth. This is my opinion. And what is the secret? Only one. Using the lingual orthodontic only to align the teeth. Forget the torque, forget the more difficult, sophisticated cases. Okay, use the lingual orthodontic, very simple treatment. And the secret, this is the first. The second, to use the adequate alloy. What is the adequate alloy? TMA, beta 3 titanium or TMA, gunmetal, or titanium niobium. And this is the alloys for the lingual orthodontic. Okay, now I'm using brackets in the lower to get the good K9 guy. We put brackets, clear buttons. I prepare the K9 guy and the end of the treatment before the aesthetic finishing of the treatment. This is my orthodontic treatment. Now it's time for the aesthetic doctor, okay, to put veneers or to put something. My objective in this patient is finishing the treatment with this. Okay, this is the patient, very, very happy with the TMG problem resolved, with the good occlusion, without pain in the mandible. Okay, and now it's time to the aesthetic finishing of the case. Another patient come to the office. I refuse Invisalign treatment. I refuse brackets. I would like Invisalign treatment. Okay, I put a removal plate. I put composite to produce the intrusion of the upper incisors. 4 brackets first, 6 brackets. Okay, a piece of wire to maintain the upper incisor, class 2 elastics. Okay, very, very cheap treatment. Okay, maybe the problem is in a little bit shift the midline, but you can see the result using a very cheap treatment. Okay, what is the result after the coronavirus? Excuse me because the presentation is in Spanish, but after the coronavirus we have a very huge crisis with a lot of low-cost clinics around the world, new digital technologies, a lot of colleagues, and the people nowadays don't have money. Okay, we have we use in my office our technique, the strike wire low friction by Rocky Mountain Company from the United States with the synergy brackets. We live in a special society. In Spanish, is VICA, is uncertainly, very complex, ambiguous, okay? And I think it's very important this. Okay, this is the different. And now we are going to work in the proprioception and guys. I think it's very interesting, this concept. What is this concept? Is instead to move the teeth, after the eruption, okay, the eruption of the teeth, and the tooth present a malocclusion, my idea is different, is to finish the orthodontic treatment at the end of the mixed dentition. And this, I think, is a very good idea. I don't have a lot of time for this because it's the opposite. And what is the idea? The idea, I try to explain this because this is in Spanish. And I try to explain this. Okay, the idea is very simple. Oh, excuse me. The idea is very simple. One moment. Excuse me for the Spanish. Okay, the first question is to treat the patient in a first phase, okay, with conventional orthodontic. What is the objective? To get the first relationship. The first point is to get a very good relationship at the level of the molars. Number two, to get a good relationship at the level of the incisor. Number three, to get a very good transversal relationship of the maxillary. Four, two good sagittal deep bite, open bite relationship. And number five, use the molars and the incisor for the retention of the appliance. We are using a space, and this is the passive guys. What is passive guys? Is the space to receive to maintain the space for the eruption of, in this case, the canine and the premolars. The active guys move during the eruption the teeth to put the teeth in the ideal future occlusion. Okay, and I think is what is the meaning of this idea? Is the control for the trigeminal nerve, for the five cranial nerve, okay, the trigeminal nerve and the facial nerve control the proprioception of the occlusion. Okay, I think the idea is this is the proprioception passive guys. This is a very hard plastic and maintain the space for the eruption of the teeth. The active proprioception guys is like a plastic and draw a way, okay, the correct way to the teeth. For example, the active proprioception guide at the level of this second premolar is moving the second premolar to distal. Okay, the attachment is in the first molar and the attachment is in the first premolar. Why? Because there is a lot of distance, a lot of time between the eruption of the first upper molar or the first upper premolar in relationship with the second upper premolar. Okay, thanks to the Alinaden, we have a very interesting research about attachment. We have a very interesting research. This is a company from Malaga in Spain, and I recommend if you like to visit Malaga because it's a wonderful city, especially for the people from Russia because it's a very hot city. It's close to Marbella, and Marbella is it's a nice place for the Russian people love Marbella, and Alinea then is 25 kilometers from Marbella. Okay, and the idea is this. This is the attachment, the paper of the attachment in my office. Okay, and this is a very simple idea. Okay, instead to starting the treatment after the eruption of the teeth, after the finish of the mixed dentition, the idea is finish the treatment at the end of the treatment. We have a lot of cases like this. You can see compare the case before and after, okay? Before and after the eruption of the second premolar and the canine, okay? And I have a lot of cases. What is the idea? The idea, very simple, is the first part of the treatment is always with the conventional, simple treatment, with Equagelis, with something like this. Second part, put attachment in the incisor and the first molars. And now it's time to put the eruption guys, okay? To the eruption guys, okay, to finish the treatment at the end of the finish. Rapid maxillary expansion, eliminate the rapid maxillary expansion, and now with the eruption guys, we prepare the patient to get a good occlusion. And you can see what is the idea. This slide represents very, very, very well our idea. Okay, we prepare the aligner to get down the canine and put the canine in the proper position. I think it's very, very interesting. The first step, very simple, the classical utility, palatal bar, and a piece of wire in the lower to maintain the space. Now it's time to finishing the treatment in the last part of the mixed dentition, finishing with the attachment and finishing with the canine. Okay, we have a lot of cases, okay, and you can see this patient, rapid maxillary expansion, remove the temporary teeth, put the attachment, and now is engage and finish the case. Class 3, okay, with the attachment, and now we are finishing the case. Okay, I suppose this is a very, very, very nice idea. Anterior crossbite in class 3, shift the mandible to the left, Frenkel class 3 and finish the treatment with a Mulligan horizontal arch wire. And now we are finishing with this. Plus, patient with a protrusion of my maxillary, a very severe protrusion overjet. First step, I love this appliance. This is a C modeler from Cervera, Dr. Cervera from Spain. After the C modeler, the 3-4 months, now introduced inside of the C modeler the aligner. Okay, we are using an aligner inside of the C modeler and prepare this space for the eruption of the canine. Decide remove the temporary molar and remove. You can see the effect and finish. Another patient with a class 3, it's not impossible to put an aligner here. It's impossible. What is the idea? Very simple, to use a Frenkel appliance because the patient need a shift to the mandible to the end, use the maxillary mandibular. A lot of people don't believe in functional appliance. I like very much. Okay, you can see now it's time to remove the from functional appliance. Why? Because it's not possible to do something with the functional appliance, finish the effect of Frenkel, finish the effect of the removal appliance. And now it's time to put the eruption proprioception guides. We use the incisor and first molar to put the attachment. Okay, and you can see the spectacular evolution of the patient with a new concept. The incisor proprioception guide, okay, check the situation at the level of the trigeminal nerve and control the muscle. And the control of the masticatory muscle produce the control of the TMG and the control of the position of the mandible. And control the growth. Crecimiento is in Spanish growth. Okay. Another patient, put a removal appliance, 4 brackets. Now remove the brackets. We are using a very simple hook in white wire. Okay, now we are working in a special plastic wire for this. Okay, to put the canine and finishing the case. Okay, I think it's very interesting because a patient with a crossbite, lateral incisor, start the treatment very simple. It's impossible to start this patient with aligners using only Quagelis in the upper, lingual arch in the lower, and now the patient is very happy. This is the grandfather of the patient, and I treated the mother many years ago. Okay, now the patient is very happy with these new appliances. It's possible to put in colors or to put something. I have a very nice brochure to show to the parents, the advantages of new design of appliances for the kids. Okay, it's something new. And now we are finishing the treatment. At the end of the eruption of the teeth. I think it's very interesting. Only a couple of a button is finishing the treatment because it's more logic, it's more ecological idea to finish the orthodontic treatment at the end of the eruption process. More cases with a class 3. We have a patient with a rapid maxillary expansion in the very early mixed dentition and finish only with a very simple. This is the occlusion of the patient. This is an experimental, okay? We make in a linear dent, okay? We make it combined between the CBCT and the intraoral scanner. Okay, the end of the patient, a patient with a class 3, a class 3 and tendency to a severe crossbite. The main problem of the patient is the mother. The mother was patient many years ago with a TMG problem, and the main problem of this patient is a TMG. Expansion with Mulligan, Stein Steel 18 with 4 loops. I like very much for expansion. Check the TMG during the treatment, okay? And now is the rest period. Rest period. Nothing. Forget the patient. And now it's time for finishing the treatment, not to start the treatment, for finishing the treatment. We are using now, remove the temporary molars, and now prepare the active proprioception guys. And please check the evolution of the patient, how the canines introduce in the passive eruption guys, and get a very good occlusion. And I think it's a nice experience. It's a very something new. It's a very nice experience. When you remove a rapid maxillary expansion, what is our attitude? Okay, now it's time to rest, forget, please come to my office after the eruption of the teeth. No, the idea is after the remotion of the rapid maxillary expansion, prepare the anterior eruption guys to finish with the ecological and not relapse orthodontic treatment. Okay, I think it's a very nice idea. It's a new approach, and nowadays it's very difficult to present in our profession, except the technological advance, because we have a lot of technological advance. But I like very much because it's a new concept. It's the new concept in the base of the new concept is the ideas of Melvin Moss about the hypothesis of the Melvin-Moss, of the functional matrix of the Melvin-Moss, the ideas of Petrovic about the servo system. And I think it's very nice to have this idea, okay, this idea to how to finish a lot of treatment immediately at the end of the mixed dentition, instead to start a lot of treatment at the end of the mixed dentition. Okay, thank you very much. Excuse me because we have a lot of material for this conference, for this module, for this webinar, and I try to talk or to set up a webinar about the removal plates only for the adult patient, removal plates and functional appliance for kids, and the use of the new concept, and this is the new concept, is the in-fissure proprioception guys. Thank you very much.